Okay, our second speaker today is Dr. Ben Kong. He's a medical oncologist and cancer researcher with interest in clinical trials and translational research. Ben has expertise in managing prostate, kidney, bladder, lung and brain cancers and interest in clinical trials in immuno-oncology. Ben consults at the Nelyun Comprehensive Cancer Centre at the Prince of Wales Hospital in Sydney, where he specialises in thoracic and head and neck cancers. He offers consultative services to those who are facing a cancer diagnosis. Ben will talk to us today about molecular profiling of brain tumours. Please welcome Ben.
Thanks, Marina, and thank you for the invitation to speak today. I'm just going to set up my own little monitor here so I don't have to crook my neck too much turning around. It's a real pleasure to be able to speak today to patients and carers. One of the great things I like about speaking to you all is that the questions you ask are often things that we as clinicians and researchers forget about, or we're too scared to ask about, or we're just so focused in our thinking that we've forgotten to think about those things. So hopefully I can the presentation I'm giving today is designed to sort of give you a bit of an overview, but certainly it may raise more questions than answers because this is a complex area. So today I'm going to talk about precision medicine, if these slides... There we go. Okay. All right. So one of the first things that we should mention here is there are many different terms that are bandied about: molecular medicine, precision medicine, genomic medicine, and tumour profiling. And essentially, in the context of clinical practice and brain tumours, I think many of these terms essentially mean the same thing. But the first step in discussing this topic is to actually understand what we're talking about, because many people think, oh, what do all these different terms really mean? So if we sort of take things back to basics, just thinking about what cancer is and what we actually mean when we're talking about precision medicine. So if we think about things at a simplistic level, we think of cancer as a genetic disease where we all know about DNA and RNA and how those chemicals program our body, and we think of cancer as a disease where there's alterations perhaps in our DNA within the tumour, or alterations within the DNA that have passed down errors throughout generations. But by and large, within tumours, we think of these as alterations that have occurred within the tumour tissue itself, giving rise to cancers. So thinking of every cell as having a genetic set of instructions, it follows that errors in those instructions can lead to cell growth and cancers. And so the science of genetic tumour profiling, or molecular sequencing, or any of those other terms that we spoke about, allows us to detect these errors and potentially think of potential treatments. So again, if we take this back to first principles, the clever scientists, not us clinicians, even though we like to take credit for that, design drugs that can match these errors or typos in cancer cells, and we think of these as being able to reroute the cells to follow the correct set of instructions. And so anytime we do genetic sequencing or profiling and discover errors in our tumours, these often correspond to potential treatments or drugs that may treat brain tumours. Now, this is a sort of picture of how we often like to think of tumour growth. Cancer is not just a sort of one bunch of cells that behave all in one similar way, but we think of them as, clusters of cells, some of which may have different profiles within them. And I often refer to these as sort of like a bunch of grapes. If you leave them in the fridge for a week, some of them will stay nice and green or red. Other ones will look rotten when you pick them out. And if I leave them out on the bench, my kids will go for the nice fresh ones and eat all those, and they're leaving all the other different colours sitting there. And I sort of think of cancer as a similar sort of process. So if we have a certain drug targeting genetic mutations, it would be nice if all of those grapes get eaten up and everything disappears. But cancer being a very heterogeneous disease where we've got all these sort of different colours or flavours of cells growing, doesn't always sort of necessarily respond in that direct way. In the context of brain tumours, of course, we have the additional challenge of getting our treatments into the brain, and there's this concept of the blood-brain barrier, which means that when we give drugs through the vein, or if you take drugs orally, they don't always make it through to the brain. And that's the particular challenge that researchers and clinicians face when we're trying to design treatments for our patients. So what's the role of genomic biomarkers or molecular profiling in brain cancer specifically? When we think about biomarkers, these may be thought of in several different circumstances. We might have biomarkers that help us with diagnosis. We may have markers that help us discuss your prognosis with you, or we may have other markers that help us predict whether certain types of cancers or tumours will respond to given drugs. And so when someone talks about genomic medicine or precision medicine, those are the different ways that we must think of these tests. So doing one test has multiple implications when we're thinking about treating brain cancers, and so this is the sort of complex journey that we go through often at the time of diagnosis. So today there are obviously many biomarkers that we may measure, but I'm trying to sort of focus on ones that are common and things that you may hear about. And these are a couple of examples of routinely tested genomic biomarkers in brain cancers. And later on in this presentation, I'm going to go through a couple that are not so routinely tested. You may have heard of a biomarker called 1p19q, which is actually a chromosomal aberration where parts of the chromosome have sort of broken off and joined together again. And this is one that's found in a type of brain tumour called oligodendrogliomas. The next one, an MGMT mutation or methylation, is a predictive biomarker. So this allows us to determine whether certain types of tumours may respond better or worse to a drug called temozolomide and other similar drugs, but doesn't have any diagnostic or prognostic significance necessarily. Further on down the table here, we've got two biomarkers called IDH, or isocitrate dehydrogenase. And that's a biomarker that until fairly recently we didn't have targetable drugs to use that were widely available, but we knew that this sort of aberration or biomarker was prognostic and told us how certain types of tumours behaved. And similarly, the biomarker down the bottom here called EGFR, or epidermal growth factor receptor, similarly has significance across diagnosis as well as prognostic and predictive value. And there's some nice pictures there which the pathologists look at down the microscope, which sort of historically corresponded to what we see now in when we do molecular sequencing of tumours. Okay, so just going through a couple of these one by one. Again, this is not a comprehensive tour of all brain cancers, but just to give you an idea of some of the commonly available and tested things. 1p19 co-deletion, the first biomarker that I talked about, is a diagnostic of a type of brain tumour called oligodendroglioma. and you may have heard of the other sort of term astrocytoma, which I guess is a more common type of brain tumour. This is not considered predictive with respect to drug treatment, but it is diagnostic, and we use this to diagnose oligodendrogliomas in addition to the old-fashioned way of looking things down the microscope. So we need all these sorts of factors to diagnose brain tumours in the modern era. The next biomarker which I had on the previous table was MGMT. I won't try to pronounce the full name of that because I get it wrong every single time. But essentially this is a aberration that's found within tumours themselves, and it predicts response to a particular drug called temozolomide, which I'm sure many of you may have heard about. So in clinical trials, when we treat brain cancers with temozolomide, we found that patients with MGMT methylation versus patients with so-called MGMT non-methylation behave differently in clinical trials. So this particular biomarker, which is tested very routinely, helps us determine whether certain types of tumours may respond better or worse to given treatments. And this is one which I certainly think that you may have heard of or will hear about. Fairly recently in various countries around the world, including Australia, where some new medications are available, although they're still being considered for subsidy, IDH mutations have become very important. IDH mutations are genetic mutations that are found in so-called lower grade gliomas as well as higher grade gliomas, being the more sort of aggressive growth gliomas. And this biomarker we've known about for many years because we know it's been a prognostic factor in gliomas or brain tumours, and fairly recently we've also been able to see that in clinical trials so-called IDH inhibitor drugs slow the growth of these tumours, and that's something which has come fairly recently, and I'm sure that you'll hear more about. So this type of marker is both prognostic as well as predictive, as I mentioned before. So that graph that we've got up here is essentially showing the different response of different types of brain tumours with and without this particular mutation. Now, I'm just going to, so this is just a bit more information about the same trial and drug that I just spoke about previously. You may have heard in the press the results of the Indigo trial, which is patients who've got recurrent IDH mutant low-grade gliomas, which was previously treated with surgery plus or minus some radiation, but now we know that adding in these drugs can improve tumour growth in these patients. So, all right, so I'm just going to move forward here, and on these sort of subsequent slides, we're getting into things that are perhaps a little bit more in the experimental realm. So we've known about many of these biomarkers, but the value of using drugs that target them is perhaps less well established in routine practice, even though these have been tried for many years. One of the biomarkers that we do measure frequently, which is called an EGFR amplification or mutation. This is similar to something we measure in other tumours. So in lung cancer, for example, but I also look after patients with lung cancer. EGFR mutations are fortunately very easily targetable, and we have great drugs that work there. In the setting of brain cancer, we're still learning about this, and we know that these mutations occur. There have been many trials ongoing, but we're still learning how to actually bring this into the clinic. But this is nevertheless something that is measured very frequently. So we know that it has prognostic value, and I guess we're looking for predictive value and how we may use our drugs better to use this. And it's likely in the future, this might be something that might require a combination strategy. So we've had many of these trials run in Australia, including right here in Melbourne, and hopefully my colleague Mal will be able to tell you a bit more about that. I'm not sure if that's part of your presentation, but that's something which we talk about frequently in the neuro-oncology world. Now again, many of you may have heard of some of the newer sorts of treatments, and one of those treatments is CAR T cells, also known as chimeric antigen receptor T cells. In this case, we're getting a little bit away from biomarkers, but the reason this has been included in this presentation today is that this sort of treatment can frequently target known genetic aberrations in tumours. Now, CAR T cells, in a nutshell, we don't have time to explain fully what this involves. These are essentially engineered immune cells that are manufactured from a patient's own immune cells and re-injected back into patients. Often these clinical trials involving CAR T cells are very small in number by their very nature, because these sorts of treatments require a lot of on-site manufacturing, and so we don't necessarily see big trials being run. But nevertheless, in theory, these CAR T cells can be manufactured to target certain genomic aberrations within tumours. Some of the common ones that have been tried are in fact CAR T cells against the EGFR mutation or amplification, which I mentioned on the previous slide. Interleukin 13 receptor alpha is another potential target. And in fact, right at the moment, or fairly recently in Adelaide, some of the groups there have been targeting a particular target called GD2. So these trials are running. They are often very small in nature, so you may not hear about them very frequently, but I think it's important to mention this, as this is something that people talk about very frequently. CAR T cells have been used a lot in blood cancers, and this is something we are learning more about in the setting of brain cancers. Now, I'm just going to skip through these last few slides a little bit more quickly, because these are certainly mutations that we do find when we look for them. And these are very, very rare mutations that may be found in perhaps a small percentage of brain cancers. BRAF mutation is one of these mutations. NTRK is another mutation that's perhaps found in less than 1% of brain tumours. And the last marker, which I'll leave to the last slide, is actually a sort of more immunological marker called tumour mutational burden. Now, the reason I've included these mutations here is that although they are very rare, we have found drugs that previously were used in other types of cancers that are showing some promise in the setting of brain tumours. So, for example, the BRAF mutation is one that's found frequently in melanoma, and there are drugs that can target this and have good efficacy in melanoma. In the setting of brain tumours, these have shown some benefit in high-grade brain tumours in terms of slowing tumour growth, and in fact the US FDA has approved some of these treatments for use. And I guess the only reason we sort of don't have them in widespread use in Australia is that these are very rare. We don't know, we haven't sort of tested a lot of these things routinely, as well as there being sort of very small populations, so it's hard to even find some of these mutations. But nevertheless, this is something which is in theory available when we do find these rare mutations. Up until now, we've been treating these through a variety of clinical trials in Australia, and on my last slide I'll show you some important information that's actually relevant to how we may find and look for these tumours in the clinic. NTRK fusions are another a very rare type of mutation, and there are some drugs which are available, some of them through access schemes, that target this particular aberration. Again, this is found in other cancers and something we're learning a bit more about, and I've deliberately put this towards the end of the presentation because this is an emerging field rather than something as well established as some of the information I presented earlier. All right, so I'm sort of getting towards the end of my presentation here. You may have heard of something called tumour mutational burden. This is not just a a one gene error, but a concept that involves measuring the entirety of the aberrations of all the genes in a tumour. And this is something which we frequently measure when we're doing genetic tests to look for errors inside tumours. Now, tumour mutational burden is a concept whereby we know that in general many solid tumours with a larger tumour mutational burden, in other words more genetic aberrations, tend to respond better in general terms to immunotherapy, and this is seen in other types of tumours. The reason I put this up here is in brain tumours, again, we're still learning about it, and paradoxically, some of the brain tumours appear to do the opposite thing to some other tumours. But nevertheless, we do measure this in tumours, and I think in the next few years we're going to see many of the immunotherapies, such as the CAR T cells that I mentioned earlier, being used. And so tumour mutational burden will be one of those things that we'll sort of talk about frequently when trying to select the right patients to treat with this with immunotherapy. We are currently in Australia running a couple of trials, one of them which I hope to mention, which is relevant to the discussion about tumour mutational burden, is a trial called the Lumos 2 trial, which is one of our COGNO trials where we are trying to match genomic aberrations or molecular aberrations with drugs. And in that trial, one of the drugs which we are using are novel immunotherapies. So the point I made about learning more about these tumours is that we are finding through these clinical trials how to better use some of these biomarkers and how to select the right patients. So hopefully some of the things we're doing in the later half of my presentation will become a bit more common, as with the things we described earlier. So where to from here? If you're a patient or a carer or someone who's involved in brain tumours, we are fortunate in Australia to have a national molecular sequencing platform called the CASP or OMICO or MOST program, depending on when you sort of come through the clinic. This is one of several platforms we have in Australia that allow patients to have their tumours screened for genetic aberrations. And this is feeding into some of our clinical trials, such as the Lumos trial. It allows us to discover those rare genomic aberrations which occur in very small populations of patients where you need to look at large numbers to find rare mutations, and also is enabling us to learn a bit more about the more aggressive types of tumours. At the moment we do have involvement in a global study called the GBM Agile study, which Mal may mention, and again we're learning about all these aberrations more as we go through these trials. On the right-hand side of this trial, I've just put some of the emerging areas in purple there. Right at the bottom corner in the right-hand area, I've put in there vaccines, and that's a sort of a bit of a catch-all term for several different types of immunotherapies. But you may be aware that some of the mRNA vaccines, such as the ones that we use for COVID, manufactured by Pfizer and Moderna, can now be amazingly manufactured for patients' individual tumours. So this is being trialled in some different types of tumours where we can obtain tumour tissue a bit more easily. So right at this moment, even in Australia, we're seeing mRNA vaccines being used against pancreas and lung cancers, very, very actively investigated. And I hope that in the very near future, we'll see that in brain tumours as well, being able to see sort of personalised vaccines being manufactured against many of these targets which we are finding in brain tumours. All right, so I think that's all I had today. Hopefully I've kept to time, but if you have any additional comments or questions, hopefully we can chat in the break. Thank you.